Hello, everyone. Welcome to today's webinar, and thank you so much for taking your precious time out to attend today. This webinar will focus on the topics of messaging, tobacco, point of sale, health equity, and disparities, and provide some best practices for talking about these topics in ways that resonate with different audiences, and provide some guidance on improving your communication efforts with your tobacco prevention and control work or other efforts that you do. My name is Jackie Boards. I am a project director at CounterTools, and I'm your moderator and host for today. And we have a lovely speaker, Dr. Julie Sweetland, who I'll introduce a little bit later, who is going to be our speaker for today. And she's going to give all of this juicy information that will be helpful for your efforts. For a little bit of webinar housekeeping, I know you all have probably used Zoom a lot. Things have gone very virtual in recent times, but I just want to go over some of the functions available to you in Zoom as a recap for those that are familiar and those that maybe haven't used Zoom before. First, you all are muted by default, and the host, which is myself, can only unmute you. If you want to talk out loud, there is that raise hand function that you can click, and that will let me know that you want to be unmuted, and I can unmute anyone on the line. There is no video option in this webinar format in Zoom, so you don't have to worry about turning on and off your video. And then lastly, if you have any questions, any comments, anything you want to say, just please drop those in the chat box or the Q&A box, and we can answer those throughout and at the end of the webinar. Please don't hesitate to just drop in anything. If something comes to mind, put that in the chat or Q&A boxes, and we'll make sure to address those. This webinar is being recorded, and the recording and slides will be made available to everyone after. You'll get a follow-up with all of that information after this webinar. I want to pause here to see if there's any other issues or any questions before we get into the content. Okay, not seeing anything. I want to first just provide a little bit of background on us at CounterTools for those not as familiar. We are a nonprofit organization that started in 2012 out of North Carolina, and we still have our main base in North Carolina, although some of us on the team work from different areas and different states. Our mission is to empower communities to become healthier places for all. We know that place has a profound impact on the health of individuals, the spaces where we live, work, learn, and play. Our homes, schools, neighborhoods, and nearby stores determine our access to healthy living. So we really focus on the point of sale in our work at CounterTools. We provide our services to help states and local communities make way for change, such as through policy, that can curb the negative impact of unhealthy products, like tobacco products, available at the point of sale. At CounterTools, as far as what we specifically do, we provide consulting, training, and webinars like today. We create storytelling materials such as infographics and maps, and give access to software tools we've developed that can be used for management of data and data collection. I know many of y'all on the line that work with us at CounterTools understand and know about those data collection tools and data visualization tools, so that's really a big piece of our work. We support advocacy efforts throughout the country, and we help to disseminate research and best practices like through our podcast, newsletters, blog, and 2 websites. Here's a snapshot of our team on the screen. As you can see, we are small but mighty, as we say. We're a dedicated team of public health nerds, policy wonks, data enthusiasts, visionaries, and storytellers on a mission to leverage our expertise for productivity and positive social change. And here is a snapshot of our partners, our current and past ones. These partners include government agencies, nonprofits, community groups, universities, and educational organizations in more than 20 states as far west as California and as far east as Massachusetts. And I want to end with talking about our stance on equity, diversity, and inclusion. We recognize that not every individual or community has equal access to healthy spaces and opportunities. Structural elements, meaning both governmental and organizational policies and practices, including those that historically have and continue to disadvantage certain groups, along with industry targeting when we're thinking about industries like the tobacco industry. This impact exposure, availability, and access to both healthy and harmful products. We define health equity to mean that everyone has a fair and just opportunity to be as healthy as they can be, which means reducing and removing structural barriers and obstacles that apply to and extend beyond the retail environment. We understand the importance and are committed to working alongside our partners to address equity, diversity, and inclusion in all the things we do internally as a team and externally with our partners. We want our work with our partners and clients to reflect the communities we collectively serve, address health disparities, and strive towards a more equitable world. We commit to addressing equity, diversity, and inclusion in our trainings, providing resources and consultation, sharing relevant data, and supporting advocacy efforts. You can see our full stance on equity, diversity, and inclusion on our website, but just know that we are very committed to this. This is in our mission to do, and this is in the work that we do around talking about things like tobacco products and industries and things like that. This idea of equity, diversity, and inclusion is very much ingrained in our work. So just wanted to make this clear that we are committed to this. Okay, let's get into our speaker for today. Dr. Julie Sweetland is a sociolinguist and a senior advisor at the Frameworks Institute. Frameworks Institute is a nonprofit that equips change makers to lead productive public conversations on scientific and social issues. Their unique approach to communications research shapes public discourse across the nation and around the world. Julie's linguistic research has focused on the intersection of language and race, with a particular focus on how language can be used to disrupt racism and other forms of oppression. Since joining Frameworks in 2012, Dr. Sweetland has co-constructed and led strategic reframing initiatives on issues like health equity, education equity, justice reform, and childhood adversity. Her skill in translating framing research into communication strategy has helped advocates, policymakers, and scientists drive social change. Since 2017, Julie has played a key role in the Tobacco Disparities Framing Project, which has informed national, state, and local efforts to advance equity-focused approaches to tobacco prevention and control. Dr. Sweetland is a graduate of Georgetown University and completed her MA and PhD in linguistics at Stanford University. So enough of my talking. I want to hand it over to Dr. Julie Sweetland to give us our content for today.
Thank you so much, Jackie, and thanks to everyone for tuning in today and making some time for what I hope will be an interesting conversation. My topic today is better conversations about health equity and tobacco point of sale strategies. This work, as Jackie mentioned, is from the Tobacco Disparities Framing Project. And at Frameworks, when we talk about framing, we mean choices in how we present ideas that lead to changes in how people think, feel, or act in response to our communications. So this is the work that we do at Frameworks Institute is help move social movements, coalitions, nonprofit, and government agencies make strategic choices about how to talk about the issues that they're working on. But this idea of framing has a long history in social science and in public health. Some of the classic, one of the classic studies that demonstrated the power of framing, how small choices, small differences in what we say can lead to big differences in how people respond, is from this study. This is one example of a study from Amos Tversky and Daniel Kahneman in the late 80s. They asked people these questions. You have to get surgery. Which procedure would you prefer? The one where 90% of patients survive or the one where 10% of patients die? Or you need to buy some gas and you can choose the sign. You're pulling into one of two stations. Which one would you choose? The one with the 5% discount for paying cash or the one with the 5% penalty for using a credit card? So you all can probably sit here and think and do the math and say, those are actually the same thing. But when we put ideas that people are unfamiliar with in front of them and they make a quick decision because our brains are designed to be fast and frugal processors of information, as it turns out, most humans, they want to survive and they want the discount, right? Even when these researchers replicated this study with surgeons, right? more surgeons than average, right, than typical would choose procedure A. So what we choose to emphasize, right, makes a difference in how people respond. Coming a little closer to home, opinions and understandings of social issues are influenced by word choice, by emphasis, by the way we talk about these things. In a recent study, we were looking to help push policies, help advance policies that would reimburse adolescent physicians and pediatricians for doing ask, advise, and ask, assess, and advise kinds of verbal interventions with youth on substance use, including tobacco. And we wanted to find out ways to talk about this in ways that didn't turn people off, but really made people more willing to support the policies that would require. So when we describe this as saying that family physicians should screen adolescents for alcohol and drug use, because we were talking about in the field was talking about that as verbal screening, we found that people rejected that idea because they associated the term screening with testing biological samples, and kind of doing a urine test for drug use felt to most people like a bit much for your 13-year-old's checkup. So they rejected that idea. Same intervention, slightly different description. When we said family physicians should ask adolescents about alcohol and drug use, people still didn't like it. They thought the purpose of asking youth about it was to catch and punish them. But same intervention, different words. We can try it again. When we said family physicians should have a conversation with adolescents about alcohol and drug use, people visualized brief verbal screenings, right? And supported the idea and the policies that would make it more widespread. So people's opinions about a particular policy are influenced by the way we describe them. Images can be framed. So as when coming even closer to home, we're starting to talk about tobacco use or tobacco use in general. If we show images of youth that seem to put them in a back alley looking disaffected and maybe even a little shady, well, then people are likely to say teens are going to be teens. No matter what we do to the policy and retail environment, kids are going to find a way. If we show a different type of image that really brings home the kind of retail environment that children are exposed to, and help support that by really saying that we've got up to 25 tobacco ads in every, in each California store, well, that can lead people to a different set of conclusions that really focuses them on the idea that there are things here within society's control, and we have a responsibility to youth to provide a healthy environment. So some quick examples of what I mean by framing, but today I'm going to get more into detail on where the Tobacco Disparities Framing Project came from, and then most of our time on some of the implications of it for advancing your work in point of sale strategies. So this is frameworks research, but definitely a project done in partnership. This is work supported through a cooperative agreement between Change Lab Solutions and the CDC's Office on Smoking and Health. We also were pleased to have additional support from the California Tobacco Control Program. And overall, as the epidemiology of tobacco-related health issues, health burdens, health environments, as that data was becoming clear that tobacco is no longer a one-size-fits-all public health threat, but really those health harms are being concentrated in particular communities. We know the CDC, Change Lab, other advocates said we need to be able to build public support for the evidence-based approaches that would eliminate tobacco-related health disparities, not only create overall reductions, but really get into eliminating the problems in the issues in the communities that are most heavily affected and most heavily targeted. And so to do that in the short term, we need to get the tobacco prevention and control community ready to frame. We need to equip and mobilize advocates like you to use evidence-based framing in your outreach, messaging, and advocacy. In the creation of this work, I won't read this to you, but we had a very robust advisory group that worked with us at every step of the way. from conceptualizing the project to designing the research questions and some of the instruments. As we were testing different things, this group helped us decide, we would want it to move this type of idea, this type of policy. And so you can see this is really a lot of the national partners that are advocating alongside and on behalf of the groups that are most disproportionately and heavily affected by the harms of commercial tobacco. And so this really was a way of ensuring that people with proximity to the problem, their perspectives are included in this project. In general, we wanted to see if we could create some big shifts in thinking on commercial tobacco prevention and control. We wanted to be able to move the conversation in terms of how people think of the responsibility for the problem, from the individual understanding to a more structural understanding. An example of a question we might use to measure that is, how large of a role do you think willpower and personal discipline play in explaining why people use tobacco products? We would want to see that go down if we say a frame is working, is making people think less about willpower and personal discipline, more about environment, structure, systems, policies. We wanted to move attribution of responsibility from the individual to the collective in terms of who's responsible. So an example of a question we would use to measure that is, in your view, how much of an obligation does our state government have to reduce tobacco use among affected populations? We wanted to make this issue more salient, feel more important and urgent to folks. An example of a question that we would use to test that is, how much of a priority do you think it should be to reduce tobacco use among these affected populations? And we wanted to build a sense of collective efficacy, a sense that if we did something, it would make a difference. I think on most social issues these days, the challenge is a little bit less to convince people that a problem exists and more to convince them that there's something we can do about it. So collective efficacy is a really important outcome of messaging that we want to see when we are doing our frame testing. So an example of how we would test for that is asking this question: how optimistic or pessimistic do you feel that we as a state or we as a nation, depending on the phase of the research, can reduce tobacco use among affected populations? And then a key and crucial point is that we were always testing our frames against these equity focused policies and programs and approaches, again, that aren't only taking a one size fits all approach and hoping to create an average reduction, but really focusing in policies that have that health equity lens to address issues in communities that are being most affected. So for example, reinvesting revenue from tobacco taxes to support healthcare programs or other programmings in communities most affected by tobacco use, a ban on menthol or other flavors, policies that restrict the number of stores that can sell tobacco in a given area, aka retailer density, and those sorts of policies. Including making behavioral health settings smoke-free, and any setting that receives funding from Medicaid smoke-free. So to figure out how we could move those kinds of ideas, we work in two big phases: landscape research, taking a descriptive approach to figuring out how people think now, and reframing research, taking a more prescriptive approach. What can we say? How should we say it to spark new thinking? Overall, this research was conducted between January 2018 and September 2019. We do this work in such a way that we are confident that it has a long shelf life. We know that social issues like these can't be solved overnight, and we need framing strategies that we can use consistently over time for 3 years, 5 years, 10 years. And so while research was conducted a little bit ago, I assure you it remains fresh and relevant. We used qualitative tools, including 77 interviews across the United States in different locations. At this point, we were still conducting research physically in person, and a lot of this is done on the virtually now. But we wanted to use sample in locations that were both within what Truth Initiative calls tobacco nations, states with weaker tobacco protection laws and higher levels of use, exposure, and negative health outcomes. as well as places without that sort of thing. We wanted a range of, East Coast, West Coast sort of thing, places with that would really give us a high level of demographic diversity. All the details of this are available to you in our published reports. And then reframing research. If we know how people are thinking, can we design some fresh, out of the box, not yet tried strategies that might work? We test those in on the street interviews, a rapid intercept interview, and then we test them. Again, we refine and winnow from those on the street interviews. We take the ones that seem promising and use a large nationally representative controlled survey experiment to see if it moves those kinds of outcomes. If this frame does a better job of moving the outcomes than that one, and the outcomes being those sorts of things I just showed you a couple slides ago, more collective responsibility, more efficacy, etc. All told, this project sampled more than 10,000 Americans. Happy to take questions around methods, but again, you can dive into the appendix of the report and find more detail than you probably want. Overall, from all that work, if I had to sum it up very simply, I would say our advice to the field working to prevent and control the harms of commercial tobacco is to stop talking about it as just a preventable health issue and instead talk about it as an unjust health issue. Taking a health equity frame on this was one of the most effective ways we found to make it more salient, to move people to support those equity-focused policies. Simply put, America knows that stuff will kill you. The tobacco control movement has done an excellent job of getting that idea into public consciousness. But the public isn't aware that commercial tobacco has a disproportionate effect on different communities, and they're certainly not aware of the policies and mechanisms that are allowing that to happen. And so to connect tobacco to people's concerns around social justice and health equity, which do exist, that is what we found would be most effective. That's the simple version. But unfortunately, framing and reframing does not work like this with the little switch. You can just toggle. It's a little bit more like this, which is a sextant used in navigation, old-timey navigation. And it's got all these, I believe the technical term is doohickeys that you can adjust and calibrate. The idea is that there's lots of different parts of the strategy that we need to align to navigate toward that end goal of getting those policies that are going to promote equity and eliminate disparities at point of sale, as well as throughout the rest of the tobacco prevention and control continuum. So overall, some of those moving parts that I just talked about, and again, this slide is available to you in the toolkits we've got, and these slides will be made available to you. But we advise framing the issue, unfolding it in stages, to lead with a call for justice, that the principle that society should be upholding here is justice, that a just and fair society values every person and their health. And our commitment to justice calls us to address the harmful role of commercial tobacco. And then help people, again, we don't need to tell them it's harmful, or spend a lot of energy on talking about how harmful it is. We do need to get people to remind them that this is something that we have our hands on. We can have our hands on as society, that there's something we're doing as a society that is making the problem worse for some and advantaging others. So the process, the mechanism that's at play here is that in general, we have widespread protections. As a nation, we've steadily expanded tobacco protections, so there's less smoke in the air, and fewer ads on the air for deadly products. And this has saved millions of lives. The problem is that those protections are uneven. Most Americans can take them for granted, but they're less likely to cover the places where people of color and other marginalized groups live, work, and learn. And I'm just using the phrase marginalized groups here as a shorthand. Specifically, you could talk about folks who are LGBTQ+, folks with behavioral health conditions, folks who live in rural areas, youth, etc. Fill in the blanks there of the priority populations. And then a solution. a proposal. What do we think we can do to make the issue better? That's where the big idea is to address policy gaps. To treat everyone fairly, we must extend tobacco protections to every community with no exceptions. What that might look like applied to or narrowed down into a point of sale strategy is something like restricting the sale of menthol. Here, this is still this idea of this idea of justice, that there's something unfair going on, that the tobacco industry has saturated Black neighborhoods. You could also say Black and Latino neighborhoods, and publications with tailored ads that try to make menthol seem like a part of the community's culture and lifestyle. And the problem is that menthol is particularly dangerous. It has that cooling effect, which makes it easier to inhale, easier to start, harder to quit. Where's the injustice in this? Where's the problem in this? Well, other flavors were banned years ago, but this particular product, the kind that causes the most harm in Black communities, they're still on the shelves. And so our proposal is that communities can begin to protect themselves now by restricting the sale of tobacco products that have any flavor, but especially menthol. And I want to give a shout out to the American Heart Association for supporting our work to take this bigger strategy and apply it to menthol in particular. So those are the kinds of framing shifts that we're going to be recommending. I'm going to dig in now and just kind of show you how we got to that. Part of it is mindsets and the where people started. I'm just going to pause for a moment and ask Jackie, is there anything in the chat or in the Q&A that we should stop and address before I move on?
I don't see anything in the chat or Q&A boxes, but yeah, if anyone has any questions or comments, feel free to put those in the chat and Q&A as we go along, and we'll answer them as Julie goes. But yeah, I don't see anything right now.
Okay, great. I'll go through this next section and then pause again. So let me know what's on your mind. All right, but what's on Americans' minds? What are the mindsets, the deeply held assumptions that people have? They may or may not even be aware of those assumptions. Again, we did in-depth interviews as well as shorter interviews with folks to see how people are thinking about the issue of commercial tobacco prevention and control and the health harms it causes and what we should be doing about it as a society. This is a real, it's clips from different locations and different interviews. And I think it's about 1.5 minutes long. This is gonna give you a quick tour of the research. It is edited to reflect kind of themes. And I'd love to see in the chat what you're hearing as you're analyzing this. What are those mindsets that folks are bringing to this topic? Here we go.
So when people smoke, right, why do you think that is?
Addiction. They get you to start smoking, then you just can't. It's a habit and it's hard to break.
It's addictive to a certain degree because of the nicotine.
You can get addicted to nicotine.
It's addictive because the nicotine in it.
That depends on the person.
It really just all depends on people, what their perspectives of it are.
It's under your own, like, I guess your own risk, I guess you could say.
At some point, you have to be responsible for your own actions.
I guess it's just something to make them feel better.
Stress, a getaway.
Stress reliever.
Sometimes to fit in socially.
I think it's 100% social.
When you're younger, you just do it because of the other kids are doing it.
They think it's something cool.
I think they think it's cool.
And do you think that some people are more likely to use tobacco than others?
If you grew up around it, yes, you're more likely to. But if you're like, you haven't, then no.
You saw all the adults do it. You wanted to be adult. You did it.
If you're surrounded by it, if you're used to it, if it's normalized.
What are some of the effects of tobacco?
Emphysema.
Emphysema.
Not breathing right.
Bad for your lungs.
Throat cancer.
Cancer.
It has like a bad connotation.
There is a stigma attached with smoking.
That it's just a disgusting habit.
And so would you say that the effects of smoking are different for some people or worse for some people than others?
Some people can smoke a bunch of tobacco and probably not ever get cancer in their life.
I know a lot of old farmers and ranchers that have smoked all their lives and they seem to be, they live into their 90s.
One person can obviously smoke for 90 years and not have a problem, and the next person can die of a heart attack at 40.
Do you have a sense of why that happens?
No, I don't.
Of course, yeah, everybody's system's different, right?
I think people are definitely genetically more prone to have the effects be worse.
I don't know. It's genetic or hereditary. I don't know.
Yeah, I mean, if you're sick, it's gonna be worse for you.
It's really just adding another factor to the existing person that a condition or the existing conditions that a person would have.
I think that if you have like asthma or if you have like secondhand smoke and you're not used to it, I feel like that would be really bad for you more than other people.
What do you think needs to happen in the country to like reduce tobacco use?
That's a good question.
Oh, I don't know. I don't know about that one.
My first thought is education.
There's a lack of education.
I think that there should be more of an awareness of the long-term effects.
It seems to me like I see more and more young people using tobacco than I ever used to.
People who are addicted are going to keep buying them regardless.
So I don't really know if there will be a way to avoid it.
It's never gonna go away until they're gone.
Yeah, I don't think they ever reduce that.
All right, so I think you probably saw a couple things there. I'm sure you saw what Nancy put into the chat. That most of the interviews see tobacco use as an individual choice. Maybe it's to fit in, maybe it's to be cool, maybe it's because that's what you grew up around. But once you're addicted, you're kind of stuck. And therefore there's nothing we can do about it. So that's one thread from cause to solutions. The other is that people are not seeing this as a disparities issue at all. Even when we prompted them, are there any differences in who's affected, how it might affect them? People individualized that. Maybe it's your genetics. Maybe you are one of those people that won this mysterious lottery that makes your body, immune to any effects from smoking. Or maybe you have a particular condition that means it's especially unhealthy for you. So people didn't, even when prompted to think about trends and differences, they didn't. And people, when it came to solutions, that was individualized too, right? We should give people more information, heighten their sense of risk. Even though we all know it's, everyone interviewed knew it was unhealthy. Those people who are smoking must not have really gotten that message because they're still making that choice. With that kind of story in mind, if we just go out into the world and start to talk about the equity dimensions, hey, this group is smoking more, this group is smoking more. I saw a headline in the Washington Post, most of America quit smoking, the poor didn't, right? We're leaving this sense that some people just didn't get the memo. They're not valuing their health. They're still making those poor health decisions. So we've actually increased stigma and blame, and we're not going to really be engendering support for the equity focused policies that we need. So Lily, that's a great question, and I will show you why. But in general, we see individualism that depends on the person, otherism, those folks are doing something wrong, or fatalism, there's nothing we can do about it, really driving this. We know from other research on health equity topics that once we start talking about groups that are racialized or marginalized, mental models of the other, if we don't do that very carefully, we are inviting these existing understandings and toxic assumptions to fill in the conversation that group, whatever that group is, just doesn't have the right values, that what affects them doesn't affect us because different groups live in different worlds. And this assumption that the solution is really awareness, that if only they knew how bad this was, they would stop. So in general, one thing that means is if we just say this is about public health, that won't be enough to break through this. We have tested the argument that this is a public health issue or a preventable public health issue on lots of public health topics, and have found pretty consistently that it's rarely the best argument. People have such an individualized sense of what health is that just saying it's about public health isn't enough for the public to really grab onto it. And if we just talk about health equity, just saying equity isn't enough either. Check this out.
So the first is equity. And I'm wondering if you all have heard that term before, might have some thoughts about what it might mean. That's all.
Like home equity?
Some sort of loan.
You bought your house for, say, 200, 250, and some years later it's worth 400. That gap there is equity.
Equity in a life insurance policy, what you've built towards something, in my opinion is equity.
Equity is kind of like basically how much leverage you have. So like you go into business or something, how much money like your business is worth.
Are you talking about money, money equality?
And if you think of equity in relation to race, what would be your guess of what it might mean?
Like racial equality, same thing? So is it equity, equality?
The sense that I get is that when people are saying equity, they mean something more specific than when they're saying equality, but I definitely have not seen it explained.
Providing everybody with the same opportunities to be able to be successful, no matter like what level they're on.
I have not heard it mentioned as far as people. I mean, normally you hear about equity in your home.
Especially if you're poor and if you're Black, you know, a lot of us, we like a couple generations removed from like slavery. So a lot of us are still trying to build from that gap and trying to get to that level where we have equity and stuff to leverage.
People have been saying racial equality forever. Why is it changing to equity now? Who's saying equity?
All right, so that's just an example of just saying equity or health equity is not going to be enough. So in general, it's important to talk about these topics as some sort of find a way to help people connect disparities, equity, and tobacco policy. Because we can't solve the problem without addressing the disparities, and we can't address the disparities without talking about the disparities. So we need some way to get that across. The question is what words will work to do that. But it's a default setting for American thinking on health is individualism. People don't know how that's happening, and we can't assume that people understand what equity means. We need some different frames. We need frames that help us, things to say that help us people understand that it's not just individualism, context matters. It's not just about them. It's we're in this together. And it's not just throw up your hands, fatalism, nothing we can do. It's that we can redesign these systems to work better and to work for all of us. So the framing strategies really work to develop these. And here they are. If your communication leaves room for people to assume that the problem lies with the people experiencing it, we need to reframe to make sure we're talking about systems and not individuals. If we're just starting with textbook numbers and saying, you know, I'm going to show you these data and that will prove to you that it's an equity issue or a disparities issue, that won't work. But it does work to lead with this ideal, this principle of justice or fairness. If we're leaving out solutions, as I've already said, or giving little picture solutions like cessation or more information, that will leave people stuck in that individualistic or fatalistic spot. And so we need to emphasize collective solutions. And another version of saying that is if we're only talking about who experiences disparities rather than how they come to be, like point of sale strategies, that's not our best frame forward. We need to center explanation and explain how point of sale strategies work. So the first one, which I think I've already covered a little bit, is to move to this idea of justice. And that's because all the other ways of leading out on this topic just don't work. When we tested that, when we said it's a preventable problem, that had no measurable effect on people's attitudes and their policy support. If we said it's an economic issue, that we've got that tobacco disparities leads to loss of productivity, increased healthcare costs, that backfired. It reduced support by 4 to 6% in experiments, and people blamed people who smoke for harming the economy. And when we talked about disparities as the last mile, then in general, we've been making great strides, but there are still some communities who are still experiencing high levels of smoking and related health problems. That backfired. It reduced public's trust and belief in tobacco control in general, and people blamed those affected groups for making poor health choices. But what did work was a clear call for fairness and justice. This increased support for those equity focused policies by 3 to 5% over a control group, which is a good and strong effect for this type of experiment. And it did that while reducing the stigma and blame on the groups that we're talking about. I don't know why those turned into question marks. Those should be little check marks. So these are like thumbs up to say things like this. Everyone deserves a fair and just opportunity to be as healthy as possible, free from the harm that commercial tobacco can cause, or talking about how achieving health equity means addressing these system-wide practices and unjust conditions, and consider the role of commercial tobacco. So these are the sorts of frames it's good to start out with. Making the story about our commitment to justice, not about health burdens, really important. Emphasizing that basic fairness is at stake and saying what you mean by equity, and then selecting your data points and your examples to really show how these practices that that are in place are unfair and uneven. Here's a couple of examples of how different states have used this already. One from Wisconsin, one from Indiana. They're quite similar. They start off in similar ways, but they connect this idea of everyone deserving a fair and just opportunity to be healthy, be free from tobacco industry influence, or free from harm. And then connecting it to the particular topic at hand. So this is the sort of thing that you could do, in talking about point of sale. Here's an example of what that would look like with point of sale. On the left, this is very focused on youth and how much they're using e-cigarettes. On the right, it's much more focused on what we're doing that allows that. And this is a point of sale example that we allow tobacco industry to package and market dangerous products in ways that keep them cheap, visible, and attractive to kids. And in some areas, 8 out of 10 stores near schools sell those flavored products like e-cigs and are more likely to stock products with candy-like flavors. So this isn't a complete message because I haven't said what to do about it, but it shows you the difference between the blue side and the plain side. Instead of trying to convince people that the problem exists, remind people of the principles that we think society should uphold and how this issue connects to it. Second strategy is to be clear that solutions exist and are within reach. As I said before, it's one thing to convince people that we've got a problem. It's another and much more important to convince them that we have solutions and that the solutions we're proposing are the right ones. If we overemphasize the problem, we can leave people in a state of despair or what can we do about it? But if we can show people that this situation is unjust and we can change it, that's when we get people to step up for change. So examples of how to make these public health solutions simple and clear is to use plain language like this that really helps people understand what we're talking about. So instead of comprehensive workplace policies, make all workplaces smoke-free with no exceptions. Instead of reversing state preemption, say what that means in plain language. Let local communities create stronger smoke-free air policies or stronger policies that regulate the stores that sell tobacco. Here are some examples of how that happens in practice, and these at the top are point of sale strategies. We can use, we can really fund our tobacco control programs. We can reduce access to flavored tobacco products. We can increase the price, and we can establish smoke-free environments. So, you can see this comes from an infographic. These numbers can improve. You can help. It's not just, again, this depressing statistics about how bad the problem is. It's really showing people what we can do. And so I start with the value, end with the solution. The meat of this is the center of this framing sandwich is explanation, helping people see what affects what. If we set up a problem and then just jump to the solution, we can be a little bit like this guy, then a miracle occurs, people aren't understanding. But if we give them a good explanation that shows what is going on, then they get the satisfying sense that they grasp the issue at hand, and that makes the information more memorable and more compelling. We also help them get smarter about kind of the basics of the issue, which then means we don't have to start a new campaign about every little tiny thing, if people are understanding, hey, the environments where we sell tobacco are where a lot of the marketing and where the tobacco industry influence happens, if people get that idea, that's a big idea that can support advertising, placement, visibility, access, all those sorts of things, pricing strategies, discounts, etc. You can really drive a lot of different policies with that one explanation. So I'm going to show you an example of what that could look like, and it does look like in this explainer video from our friends at Tobacco Free Nebraska. And they really walk through how point of sale strategies happen, and they do this wonderful job of connecting historical tobacco industry marketing practices to contemporary ones, which we found was an important strategy. Americans have this general sense that the tobacco industry is a big nefarious player, but they are not remembering the 90s like we are. And so you can't assume that just the phrase big tobacco and its playbook, right, are still resonating. We have to show people and remind people what that looks like. This is, I think, 150-second spot. And there are shorter versions of it available, but I would just love you to pull out where you see explanation and where you see the visuals supporting the explanation. How is it that how is it they're making this simple and easy to understand?
Welcome to the wild world of tobacco advertising. It's been around our whole lives, broadcasted on TV and radio for many of us, and littered within the boundaries of our shared communities nationwide. With smoking being the leading cause of preventable death in the U.S., policy changes over the years have been instrumental to shadowing the tobacco industry's marketing reach. But the industry's effort to influence the masses continues to adapt and evolve right before our eyes. Enter point-of-sale tobacco advertising, a space so run-of-the-mill, so unassuming that the tobacco industry's strategic pivot to point-of-sale locations is masked by commonality, hidden in plain sight. The tobacco industry spends approximately $1 million an hour advertising and promoting tobacco products and other forms of electronic smoking devices. They know hiding in plain sight to fly under the radar is a powerful tool, and the opportunities point-of-sale locations offer for this manipulative marketing approach. So the tobacco industry deliberately cuts through the clutter by becoming a part of it, strategically positioning itself to influence the masses by evolving here as part of our everyday. Nearly 96% of the tobacco industry's marketing dollars are spent on point-of-sale efforts. Of those dollars spent, the tobacco industry puts an even greater focus on low-income and minority areas, in addition to places children frequent. There are policy options that reduce tobacco use and keep kids from ever starting. Positive traction in this area is achievable with shared focus and collaboration. Now, your awareness can help expose the tobacco industry's efforts for what they are. More of the same at point-of-sale locations. Take an important stand against the tobacco industry by shining a light alongside others in your community today.
So I particularly love the visual where they show the eye lines. Also the constant, they made really effective use of the animation of continually updating, moving from the cowboy era to more to the contemporary era, but then the ads flipping all the time. So that's when I talk about explanation, that's the sort of thing I mean. Explanation doesn't always have to be lengthy. This is, a little longer than what you might have. You might not always have time for something this in depth, but it is one effective tactic that's available for us. An in-depth explainer is always available to us, but an explanation can be short as well. The final strategy I want to talk about for explanation is metaphor. We tested several different metaphors, roadblocks, and other sorts of things to help people understand how there are all these social and environmental stressors and factors that increase both tobacco use as well as compound health problems in affected communities. And marketing is one of them. Those point of sale strategies are one of those environmental factors. So the gist of the metaphor, if you were on early, I played Under Pressure by Queen and David Bowie. This metaphor is a pressure metaphor, that the pressures in an environment affect tobacco use. They push people towards tobacco use. As many kinds of stressors and influences build up, the combined force can increase health problems related to tobacco. In our testing of this metaphor, we found that it helped people understand that racism and discrimination are a form of stress that help to explain, for instance, why LGBT youth smoke at twice the rates of their straight peers. A response to social isolation and discrimination. But it also helped people understand the pressure, the continuous pressure of marketing, like was shown in that explainer. We started out with videos of people kind of not quite getting it or thinking in ways that we know aren't in line with the science. I want to show you now, there's again, an edited reel that condenses and collapses a lot of the data we've got on this metaphor, but it shows how people can and do think about tobacco disparities as a social justice issue, as an environmentally driven issue, when exposed to this particular metaphor.
What is the main idea that passage was trying to get across?
It's basically saying that pressure leads to people using tobacco.
It keeps pressing us more, which means like in a lot of fashion, more stuff, which is pressure.
The additional pressure would cause people to actually look for gateways to, I guess, better themselves or, make them feel better.
And so what is that pressure metaphor saying about why people use tobacco?
Complete stress, and it permeates your thinking, and you're thinking about a way to escape that stress.
People are really stressed out and stuff like that. I mean, that's just an easy coping mechanism.
Well, I think it's stress relief.
Oh, that's much better. That's what you see on the TV. Take a puff. Oh, that was great. Now I feel better.
Our society does put kind of a burden on people.
Like not having jobs and things like that, that get people in stress like that.
And thinking about that idea of pressure, does it say anything about whether some people might be more likely to use tobacco than others?
The social and economical and the additional stresses.
The constant threat of unemployment, economic disadvantage.
I guess for people, money situations, I know like that's a big thing.
What do you think needs to happen to reduce tobacco use across the country?
The less tobacco that's out there would minimize the use of it.
For underserved communities, you need an outlet and to figure out what to do with all that bottled up economic stress.
They would find a way to reverse that instead of people looking for tobacco as that outlet, to let the stress go. They should invest in communities.
Take the money from tobacco and taxes and funneling them back in towards a solution.
Communities really need to focus on activities that encourages people to take action in being healthy every single day.
So here, where people started out with a very individualized understanding of what drives tobacco use, what we tried to do with this metaphor was take one productive idea they have was, people are stressed out and that's one of the reasons they smoke. And we tried to expand it to, poverty is stressing people, unemployment or economic policies, community conditions, and constant flood of marketing, right, is pushing them towards this particular thing. And that really let people think, oh, yes, well, that's something we can do about. We can create healthy conditions in communities. We can reduce access to tobacco. We can invest in communities to ensure that they're getting the best of tobacco prevention and control. So I'm just going to zip through here. In general, this is not a script. This is not a bumper sticker or a slogan. It's a strategy to take our communications on the equity dimensions of commercial tobacco from looking like this to at least looking a little bit more like this. So some of you are working on pricing strategies. Some of you are working on marketing strategies. Some of you feel that you can go very strongly, in a context where you can really lean into the effects on priority populations. And some of you feel like you may, are in a context where that may be a little bit less of a harder argument to make. So that's okay, as long as people are still moving in the same direction. And we realize that some of the ways of talking about tobacco prevention and control aren't helping us. So we've got the boundaries around what we're saying. We know from lots of research that this can make a big difference, again, in the strategies people are willing to support. I saw lots of questions in the chat about how can we get this? How can we get that? We're absolutely, this is an open source strategy. And we will share the slides from today. There's also on our partners website, changelabsolutions.org, lots of resources. So I would particularly point you all to the resource called Pointing Out Inequity. It's a curated list of data-based talking points, and there's lots of stuff in there on point of sale. Candy more like tobacco being more likely to be displayed near candy in neighborhoods where there are higher numbers of Black children, for instance. Those sorts of things are pointed out there, and you can absolutely use them. In general, again, framing is just one part of the work that you all are doing. But the world changes, James Baldwin told us, according to the way people see it. And if you can alter even by a millimeter the way people look at reality, then you can change the world. I think this strategy, these insights, these evidence-based tactics will let you make a lot more change than just a millimeter. And I really hope that you find them useful in your work to change the world. We got a minute or two of questions, but you guys haven't been particularly chatty, so I decided to take a little bit longer with the explanation. That said, if you've got something to say, let's hear it. Over to you, Jackie, to moderate.
Yeah, thank you so much, Julie. That was great. And yeah, if anyone has any questions or comments, we can stay a little bit later and answer anything. And certainly if anything comes up after, you can email us at Kenner Tools, and we can get you in contact with Julie or answer the questions that you have on this topic. But yeah, we'll pause here for any remaining questions. And we really hope this information was helpful and gave you all a sense of, how to frame, how to message, what works best, what doesn't. This is very important. I know we at Carter Tools are all about messaging, and it's so important of how you talk about these topics to move the needle forward. So I really appreciate this information from Frameworks. We use a lot of their resources. I definitely recommend to check out all that Frameworks has, and even Changelab Solutions has. It's very helpful. So thank you all so much for your time. And like I said, we'll stay on if y'all have any further questions or comments.
Thank you for that, Jackie. I will say 99% of our research is up on our website, frameworksinstitute.org. There are a couple topics that we keep close hold or post elsewhere. So the tobacco work is on the Changelab website. But yeah, all still open access. You guys can dig into it. And yeah, my virtual door is open to anyone that may need a framing co-conspirator.
And I'll go ahead and put our contact on the screen if you all want to contact us at Kenner Tools. That is our email, hello@kennertools.org. We can help you out. Yeah, we have some good comments in the chat. I think that we need to reframe how we advocate for policy change with our legislatures in Indiana. Yep, for sure. It's reframing, how we even talk about policies and such. Mm-hmm.
The Indiana Department of Health has been very active in kind of an early adopter of this strategy. So a whole team from Indiana Department of Health attended a test and learn collaborative that we did for folks at state and local health departments. And I spoke at the Indiana Tobacco Exchange, I think it was called, a few months ago. So Nancy, look that up, and you've definitely got some fellow friends, other Hoosiers working on this. So you've got friends around.
Mm-hmm. Yeah, we have another shout out from Indiana. Cigarette tax increase is what Indiana needs. Yep, there's some Indiana folks on here. Mm-hmm. Very true.
Yeah, and people often think that, the economic argument is the only way to get to conservative legislators. And there's a grain of truth to that, right? You got to you have to style shift with different audiences. You speak to congregations and sermons, speak to legislators and budgets, right? I mean, that's just one of the bullet points in budget. So there's some of that. But using economic data as a supporting point is different than putting all your chips, right, on the economic frame. And so a fairness and justice frame, workers, right, no matter where Hoosiers are, they should be able to breathe clean air. So congratulations on the smoke-free casino in Terre Haute. And keep pushing in that direction. Nebraska has done a lot of great work. I don't know what else I've got from there. I mean, I showed 2 examples from them and probably could have shown more, but I don't know more. You might, Jackie.
Yeah. We work with Nebraska Counter Tools, so yeah, we can pick their brains to see what else we can get from Nebraska as far as some examples of what they're doing. Yeah. And we have a good point from Nancy. Our messaging on the advocacy front has remained mirrored in the health risks and economic costs messaging, and it isn't moving them at all. So I think that just, explains what you were talking about, Julie, throughout.
No, I was responding to her. I didn't say the part where I was responding to Nancy out loud, but I was. So, and then, okay, so the justice and equity messaging with conservative policymakers. So nobody can ever do rigorous testing with policymakers. You can't get them to be research subjects, right? So here's what I can tell you, and here's what our research does show and what it doesn't show. The idea around justice and fairness and everybody, right, should have this chance, but we're not providing this chance or this protection. That argument does work. Okay. If you use the word equity, right, it has been politicized and called out as kind of a telltale sign of progressive woke agenda, so I wouldn't necessarily recommend that word, but that argument, yes, we do see that resonating strongly with rank and file Republicans. Policymakers, what will the framing is only one part, right, of how to reach them. There's the relationships, there's the particular incentives and pressures that they have on them. So to some extent, we think this strategy is change their incentives by changing what the public thinks and what the public is asking for. So you can definitely influence those legislators by building a bigger constituency and a louder voice for good tobacco control policy. But I would not assume that a justice frame would backfire just because someone is an elected Republican official, right? I would assume that the word equity might cause a distracting conversation to follow. Yes, yeah, the sense that we did see that tobacco use makes people poor, not that being poor makes people use tobacco, right? We did see that in our longer form interviews, and you can get into that in the report. And so part of shifting that assumption, right, showing that people who live in low income communities are exposed to up to 3 times, the number of ads. People with behavioral health conditions are targeted, right, in very intentional ways, and left out, excluded from protective policies, right, through tobacco industry lobbying. So I think when you show people just that rates are uneven group by group, that doesn't do much. You have to show that something's uneven and it's unfair, right? You got to show where the injustice is, even if you don't say the word injustice, right? Showing, well, every other healthcare setting, right, is tobacco free. We assume that people with behavioral health conditions don't want to quit. They actually do, right? More than half have said they want to quit. And we know that their outcomes are better when we support them, right, in that journey. And they're in neighborhoods with twice the number of stores that sell tobacco. So can we level that playing field, right? So there's there's a way to make the case, but it's about showing not just that things are uneven, but that they're uneven and unfair, and that the unfairness is on us.
Thank you, thank you. Well, I think we can go ahead and end things. And like I said, if reach out, I'll send that follow-up email with the slides and recording, and reach out if you have any further questions. If you just want to pick our brains, let us know. There's a lot out there to support you all in your messaging and communication efforts. So thank you again to Dr. Julie Sweetland, and you all have a good rest of your day.